Hello, my name is Janet and I'm a publisher with Elsevier. Medicine Journal is a collection of current reviews for internal medicine training exam revision, as well as for continuing professional development. Medicine's Editorial Board comprises of subject matter experts across all subspecialties of clinical internal medicine. As we publish each chapter in the journal, our chairman, Albert Ferro, will be interviewing the relevant board member and chatting to them about their specialty. We hope you enjoy them. To find out more about Medicine Journal, including how to subscribe, please visit www.medicinejournal.co.uk. You can also follow us on Twitter using the handle @MedicineUK1.
Hello, I'm Albert Ferro. I'm a clinical pharmacologist and the chairman of the editorial board of the journal Medicine. I'm very glad to be joined today by Dr Uma Nath, who's a neurologist, and she's with me because this month's edition of Medicine, this is August 2023, is centred around neurology, and Uma has been co-editing that issue. So welcome to you, Uma. Very nice to have you here.
Thank you. Very nice to be here, Albert.
Good. Okay, well, maybe you could start off by just telling us a little bit about yourself.
Happy to. So I work in Sunderland and South Tyneside, so the northeast of England, and I do inpatient work, but I'm mainly an outpatient specialist. So I see, in fact, quite a lot of the disorders that we'll be talking about in this video cast in my general neurology clinics, and I happen to have an interest in Parkinson's as well.
Thank you very much. And a lot of what we'll be talking about, of course, is stuff that's very relevant to general medicine, because, of course, there's a lot of specialist stuff and we won't really go into that too much. And I guess one of the things I'd like to start off talking with you about is this concept, which I think dates back to, in my time, neurology was considered an area where all the diseases were pretty much untreatable. And I think you would probably say things have changed and things are a bit different now. So I wonder if you could tell us a bit about that, what your views are. Is neurology a collection of untreatable diseases, or are there things that we can do something about now?
I'm so glad you asked that question in order to allow me to refute it. Indeed, I know exactly what you mean. Neurology used to be considered the realm of diseases that were very rare, relentlessly progressive, and untreatable. And it's a fallacy, Albert. I honestly don't think it was ever true, but nowadays I actually think this edition of the journal just reflects how untrue it is, because the breadth of articles, we've got articles in this edition, very basic neurology, like lumbar punctures, when to do them, and pertinently when not to do them. But there's a whole article on autoimmune diseases in neurology, which are quite common and very much treatable. In fact, if you miss them, you have a problem, because then they become irreversible. And it's a really exciting new field, which, if I think back to my old textbooks of neurology, it just, apart from myasthenia, perhaps, myasthenia gravis, it just wouldn't have been mentioned. So common, very much treatable, important to recognise early.
That's good to know. Thank you. And I guess one of the other things about neurology, and I always found this when I was a medical student, when I was a junior doctor, and I think this is a common thing that people find, is that it's one of the harder systems when you're clerking a patient. Cardiovascular, respiratory, it all seems, by comparison, very easy in terms of history and examination. I think there's in the current issue, there are a couple of very useful articles which cover history and examination. And I wonder if you could maybe just give us a few brief insights as to, the salient elements of doing a good history and examination in neurology.
I know exactly what you mean. There's even a term, they've coined this term, neurophobia, which is fear or avoidance of neurology. And your experience is actually very common. It's shared among many people. And one of the nice things about this kind of twin set, this pair of articles, one on history, one on examination, as you say, is that it shows there's a few practical tips, there's quick facts for the time-pressured clinician. And a couple of points I thought were very interesting. And one that Moodley makes is that even though we spend a lot of time training people on the structured neurological exam, it's actually the history. That's the cornerstone of neurological diagnosis, and that's how you limit your differential. And for example, if you've got a patient, if you just think about the onset of the disease in the history, the rate of onset, and the sequence of events or the course, you can limit your differential enormously. If you're talking about someone who had a subacute onset of a neurological symptom, like weakness, came on over weeks, got to its nadir, plateaued a bit, and deteriorated, and resolved. That's very different from a hyperacute onset, which would be more vascular, with the former being more neuroinflammatory.
And I think I would certainly sort of tell viewers and listeners to go to those articles, because I think they're really useful. Maybe we could sort of turn to a couple of medical problems that face the general physician, which always cause a bit of difficulty. And maybe the first one we could touch on is dementia, because there is an article on dementia in the issue, and it's obviously an important area that doctors need to understand well, because it's very prevalent, of course, and it's a major cause of cognitive impairment. I think it's also true to say, though, that there are many other causes of cognitive dysfunction. So I wonder if you might just sort of tell us a little bit about this. What are your feelings around the important things that the general physician should know about dementia and cognitive impairment in a patient that presents?
I think this is a very lucid article in an area that people often find difficult, trainees often find difficult. And I guess the key point is that dementia is not one thing, it's a syndrome. And there's a number of different pathologies that can cause it. And they all have different signatures based on their varying combinations of cognitive, behavioral and neurological features. And especially in the early stages, they are very different. And it's really important to know this, because there are encephalitic causes. So encephalopathy is our word for cognitive impairment. And there's so many reversible causes of that it's important not to miss them and not assume that dementia is one thing and that it is a neurodegenerative thing, because, the field is so much wider than that. And I mean, in fact, if you think about different causes of cognitive impairment that a physician will commonly see, encephalitis, one, Wernicke's encephalopathy, potentially normal pressure hydrocephalus. People are going to come across these things, and they can all present with cognitive impairment. So where are your red flags, and how can you point towards a reversible cause as opposed to a neurodegenerative one? I think if you think about Wernicke's, you may think someone with alcoholism, the red flag would be there, and you'd give them the thiamine early. But would you necessarily think of it in a pregnant woman who was vomiting? Would you think about it in someone with gastric banding, hyperemesis for other reasons, or malnutrition, haven't been fed a long time? So think about it there, and particularly in patients who have diplopia and balance problems as well. I would also say, if a patient has seizures in conjunction with cognitive impairment, that is a red flag. And the article suggests that you have to think about encephalitis, and particularly there is a plethora of neurological autoimmune inflammatory disorders linked to specific antibodies, so specific phenotypes of cognitive decline and seizures. Linked to these antibodies, you've got to start picking them up early, because they're reversible in their early stages, and if not, they will progress to dementia. It's important, even the causes that you can't treat, you've really got to be aware of them. Like, for example, if you had someone with a very rapid decline over weeks, I'd be thinking of prion disease or Creutzfeldt-Jakob disease. And one of the clues, the big clue, is a rapid decline over weeks. But the other clue is myoclonus, or shock-like contractions. So that's another thing. I would say one other differential. The article highlights you've got to ask about sleep. Sleep is important, in fact, in the autoimmune disorders, but it's also very relevant in what's called Lewy body dementias, where, and this is a neurodegenerative cause of dementia, but a characteristic one with its own specific management. And you'll find that these patients have loss of REM atonia, so they thrash about, they kick, they can injure themselves or their partner at night. Very easily treatable, usually with a bit of clonazepam, and it can be quite disruptive, and patients may not mention it because they won't link it to their cognitive impairment. You've got to ask about that. If patients or carers describe that the patient's very fluctuating, sometimes they have absolutely terrible days and sometimes they have all normal, that, especially if they've got visual hallucinations as well, is quite characteristic of a Lewy body process dementia. And if you do an objective test, like a mini mental score or better, an Addenbrooke score, you'll get specific focal deficits in attention and visuospatial, particularly. I mean, their clock drawings can be very bizarre. So that's useful. I think that it's important to remember that this is the real world we practice in, and patients may have more than one thing. They may have vascular disease in conjunction with Alzheimer's, for example. And we mustn't forget, because it's common and increasingly so with an aging population, we mustn't forget that it's a devastating thing to tell someone, and rather than leave them hanging after your short clinic appointment, try and reference support groups and societies that you can refer them to that can help as well. And I would mention the Alzheimer's Society, or rare dementia support is very good if you don't yet know the diagnosis.
So some important messages there. Importantly, I guess what you've highlighted is that you have to be able to distinguish the reversible from the non-reversible causes. And even in the non-reversible, there may be a lot of value in specific features which will distinguish one form from another. I guess Alzheimer's is very much in the news at the moment, isn't it? Because of the newer drugs that are coming along, which seem very promising in its treatment. So I guess this is something that maybe in the next iteration of medicine we might be saying a lot more about.
I think absolutely. I hesitate to call anything untreatable in neurology these days. We've really made huge advances. We're catching up with the rest of medicine, and yes, absolutely, exciting time.
Great, thank you. Thanks, Uma. Another very common medical problem, of course, is dizziness. The patient who presents dizzy, and there are so many possible systems that can be responsible. So it could be cardiovascular, ENT causes, and then of course we've got neurological causes as well. Again, there is an excellent article on this in the August issue. Maybe I could ask you, what would be your approach to the patient that presents to the ED with dizziness?
I agree. This article is really lucid. And again, it's an area people struggle with. And we need to get it right, because dizziness is very common and it will present to a number of specialists, whether in the Falls Clinic or cardiology, neurology, as you say. It's also multifactorial, and the difficulty is that sometimes patients themselves find it very difficult to describe, and we would ourselves, because it's a very subjective sensation that's difficult. And patients have described it to me as floaty, off balance, dizzy, not just vertigo. They might say they're lightheaded or just feel generally unwell. They can be very non-specific about it, and you've got to prize out what is the symptom and if it is vertigo. And that's what we're looking for here. And if you find a patient has vertigo, then the question is whether it's central, so caused by a stroke, and that is more likely to be one of the what you'd call more serious or brainstem or posterior circulation stroke, or a vestibular disorder of the middle ear. And you want to get it right, because you don't want to miss a stroke which could be thrombolized and cured, significant implications for the patient, as opposed to a peripheral disorder, which is uncomfortable but not life-threatening in the same way. And that one of the problems or challenges is that MRI and DWI sequences, so the sensitive sequences for stroke, can actually be negative. They can be normal in the first 24 hours. So you may think, well, I'll know if the patient has a stroke because there's all the other stroke type features. But the fact is, and perhaps this is the key take home I got from this article, that isolated vertigo can be a presenting symptom of a stroke. And so the authors actually give one of these quick hacks or practical tips I was talking about. And this is called the HINTS test, HINTS. It's an acronym, and it stands for Head Impulse Test. See if I get this right. Head Impulse Test, Nystagmus, and Test of Skew. And what they say is it's got a very good reliability for a test that's so quick to do, to be specific, to distinguish between the peripheral and the central disorders. And I'd refer readers to that article because it's very nicely described. But may I just talk about the head impulse test, Albert, because it's quite useful.
Yes.
So the way you do it, you get the patient, it's a clinical test, you get the patient to fix, so stand in front of you, sit in front of you, fix on your nose. And then if you ask them to fix visually on your nose, you then tell them you're going to do this and you move ahead quickly, you sort of thrust it, a small amplitude thrust side. And what you'll find is if their vestibulo-ocular reflex is intact, then they will be able to maintain fixation on your nose wherever their head is. But if it's not intact, then they'll lose fixation temporarily, and then they'll have what's called a catch-up eye movement or a catch-up spade to get their eyes in the right position. And so basically, if a head impulse test is normal, that means your VOR is intact and there is a central problem like a stroke. So there you have a problem. If the test is normal, you have a problem. And if the test is abnormal, then you have a vestibular or less serious problem. So you then, I guess the next question is, if you've got your patient and you've done your clinical test, when would you need to scan? And I think sometimes it's very obvious, but there's a few pointers they give in the article to where it might be less obvious, whether it's peripheral or central. And I think isolated vertigo is one of those, where there's a few tips for when to scan. And mainly they make sense. So sudden onset symptoms. If the patient's so off balance they're unable to walk, if they've got brainstem signs, dysarthria, a squint, you wouldn't get these in a peripheral disorder. And of course, if their HINTS test shows a normal head impulse test, that is more towards a central problem. So I guess new headache as well. So in terms of what imaging to do, just to emphasize that MR is more sensitive than CT, but a CT is often done, and it's important because you exclude a bleed or a hemorrhage. It wouldn't pick up the other things. So if you then haven't found on your clinical assessment or the MR, if you haven't found a stroke, then think about something that is the commonest cause of continuous vertigo lasting more than a day, which is a labyrinthitis. Now actually it's called a number of different things, but it's now we're meant to call it acute peripheral vestibulopathy. And patients can be really uncomfortable, off balance with it. It's a subacute onset over days, but it can get so bad that even with their eyes closed, they feel like they're falling or floating. And they may have horizontal nystagmus, they may be vomiting. It's very severe, but it usually spontaneously resolves. And it is clearly, it's not a stroke, but these are the ways one can distinguish them. And that's the acute onset for the first time. I mean, if a patient keeps presenting, so they have recurrent vertigo, the differential becomes slightly different. And I would think about things like vestibular migraine or BPPV, which is benign paroxysmal positional vertigo.
That's a very useful guide through dizziness and vertigo. Thank you. Let's turn to epilepsy. Again, there's an excellent article on epilepsy in the issue. Again, a very common disorder seen by general physicians. Maybe we could start with a bit of a definition of epilepsy, what it is, how we make the diagnosis, and importantly, how we distinguish dissociative fits from organic fits. So there's a few questions buried in there, but maybe something around definitions, diagnosis, and the difference between dissociative and organic fits.
Indeed. I mean, I really commend this article. I think Angus Lepan and colleagues talked about an important common disorder and really highlighted the key points. So I'll go through some of your questions. So definitions. Start off with the definition of a seizure, which is basically an abnormal electrical discharge. And if you have two or more of those, and they've got to be 24 hours apart to be defined as more than one. So if they have two or more than 24 hours apart, then that is epilepsy. That's your definition. The ILEA, the new classification system in 2017, has got a lot of practical tips. And one important one is that if you have just one seizure, so the classic definition of epilepsy does not pertain to one seizure, if you also have abnormal investigations, either an abnormal MR or an abnormal EEG, electroencephalogram, then that increases your risk of a second fit. And this prognosis is what everyone's worried about. If I have one, will I have another? So it increases the risk to over 60%. And in the first year. And in that circumstance, there's a lot of implications for the patient, and there could be implications for treatment because they have such a high risk of it recurring, or it could be implications for driving, also important. So in terms of what you said about how to diagnose it, well, it's very much a clinical diagnosis. You've really got to be thinking about what happened before the attack, during the attack, and after the attack. And by its nature, if you've had a tonic-clonic seizure, you won't be aware during the attack. And this is why collateral is so essential in restricting the differential, because you want to get it right. And not only are witnesses very important for during the attack, sometimes they can tell you much more context before and after, because the patient may be quite spaced out after the attack. And I think that these days we use technology and we allow technology to help us. And patients have been at the forefront of this, and they get their carers or their relatives to do a little clip on their phones, and they can send it to us securely, and that can be invaluable too. If you had a patient who was standing up when an attack happened and they were noted to be pale, sweaty, if they felt lightheaded, or they had tinnitus, or they had blurred vision, then all these things would point, and I think most people would recognise this, to a pre-syncopal or a syncopal cause. Particularly in the elderly, there's something called cardiogenic drop attacks, and I think that's part of the reason why ECG, certainly in the UK, according to guidelines, is mandatory. The actual investigations I've come on to are MRI and EEG, and you've really got to remember that an EEG is not necessary or sufficient for the diagnosis. Commonly normal in epilepsy.
That's quite interesting what you say, and that's where a lot of people, I think, get a bit confused, because in between attacks, of course, an EEG may be completely normal. I guess the important thing is if they're having a seizure and the EEG is abnormal, then that's more useful. Then is that right to say? Absolutely.
And I mean, that brings me very neatly onto what we were talking about, non-epileptic attack disorder. And that's a preferred term to dissociative seizures. There's loads of terms, there's no agreement, but they're very common, these dissociative or non-epileptic attack disorders, and most physicians will come across them. And the clues here, there are quite a few. And one of them is the attacks are not stereotyped. They can be different each time, whereas what you might call organic epileptic seizure, it'll be stereotyped. It'll happen in the same sort of sequence, same aura. So something else that might happen, it can be very dramatic. It can be an explosive onset with these attacks. If they're having an attack and they resist eye opening, so if the patient resists eye opening, that does imply a level of awareness and is reassuring against a genuine epileptic seizure. And the other thing to say is the patient sometimes themselves can volunteer and do volunteer that I could actually hear during the event. I couldn't speak, I couldn't move, but I could hear. And if they're having a tonic-clonic event, that doesn't fit with an organic tonic-clonic event. And sometimes they can be very prolonged, and yet the patient can recover very rapidly afterwards. So there isn't really a long post-ictal phase. And it brings me on to what you said about EEG. If you can capture a suspected attack and the patient has one during the EEG, it will be normal in a non-epileptic attack disorder, and that is the mnemonic, that is diagnosis nailed on if that is one of their typical attacks. The only caveat, and there's always a but, isn't there? The only caveat is that frontal lobe seizures, which are very rare, can look really bizarre. They can look functional, and surface EEG can be normal. Out with that, I think it's a very useful test to do.
And maybe this is also a vast subject, I guess, management of epilepsy and seizures. I don't expect we've really got time to go through all of that, but are there any important messages about management that you'd like to tell us about? Yes,
quite a few. And as you say, just refer to the article. If I had one take-home message, it's that an epilepsy nurse is essential to support patients, because there's so much to say about this. Two specifics. Anti-seizure medications are clearly very important. And I think you need to have a passing knowledge or a working knowledge of the important side effects. The ubiquitous Keppra or levetiracetam, really effective drug, very safe. However, just remember that it is associated with aggression, low mood, suicidality, and depression. So it can affect people's mental health, and they may not link the two things. The other thing to remember is which drugs cause a nasty rash. Now, almost all drugs can cause a rash, allergic reaction, but carbamazepine and lamotrigine can cause a nasty rash, by which I mean they can both cause a Stevens-Johnson syndrome type rash. And that is why, particularly with lamotrigine, that the titration schedule is very slow. It is 25 milligrams per fortnight maximum. So you've got to keep watching out for this rash. And that's why it takes longer to get the patient onto a therapy, which is why the levetiracetam is so good, but you've got to bear in mind the side effects. I will mention sodium valproate.
Yes,
it's a really, really effective drug. It comes with a big caveat for women of childbearing age. And there's something called the PREVENT program, which means that every woman of childbearing age has to be on highly effective contraception. The drug is teratogenic, there's no doubt, and it's relatively teratogenic compared to the others. And so it's really important that patients are aware of this, and it's part of their preconception counselling about epilepsy. There are lots of aspects of preconception counselling. Before I forget, I must say that if drugs don't work, if anti-seizure medications don't work, that is what we call refractory epilepsy, and there are surgical options now. And again, I'd commend the reader to the article.
And still on the subject of epilepsy, it might be worth just saying a word or two about the DVLA rules around this.
Patients may not necessarily mention driving, and why would they? They've got plenty else to think about after a very frightening event like a blackout. You've got to ask. It's essential because you need to provide them with guidance. You're not telling them what to do, but you're giving them what the DVLA guidelines are and advising to inform the DVLA. And I guess the important take-homes, very simply, I mean, have a look at the DVLA at-a-glance guide for medical professionals, but the simple facts are that if you have one seizure with normal investigations, it's 6 months of driving, usually. But if your investigation, either MR or EEG, are abnormal, that does stretch it because of the increased risk of recurrence. It stretches to 12 months, and that can have a huge impact on patients and their families and their employment. So definitely worth talking about it, but you have legally to talk about it.
There's obviously a lot more in the issue than we've got time to cover here. Maybe we might just sort of close with the article on lumbar puncture and CSF analysis. Again, it's obviously very relevant to general physicians. And maybe just a word or two, we could talk about when is a lumbar puncture useful, importantly, when not to do a lumbar puncture as well. Maybe I could just ask you to say a few words around that.
Lumbar puncture, really essential. It's a routine procedure, a very common procedure rather, in the acute medical take. Most physicians will be familiar with it, or should. And it's also used in the investigation of neurological disease, in the elective outpatient investigation. So when to do it? When would we consider doing it? Well, obviously, acutely on the medical take, you'd think about encephalitis, meningitis, including subarachnoid hemorrhage, absolutely essential. We also think about it in neurological disorders which are inflammatory, necessarily infective. So inflammatory, either multiple sclerosis or peripheral disorders like Guillain-Barré syndrome. Mm-hmm. And you know that in Guillain-Barré syndrome, what we're looking for is raised CSF protein particularly. It's really important to remember that LP is a diagnostic and a therapeutic tool as well. And one of the important areas it's used as the therapy is in something called idiopathic intracranial hypertension. Used to be called benign intracranial hypertension, but absolutely we don't like that term because it's not benign. And if you miss it and you don't treat these patients by this therapeutic tool and lower the CSF pressure, then there can be irreversible effects on their optic nerves and they can lose vision irreversibly. So that's when I would consider doing it for therapy or for a diagnosis. Now, coming on to the important issue of when you wouldn't do it or when you would consider very carefully before putting that needle in. The article has all the points listed, but let me tell you the main ones. What you're looking at here is you don't want to be LPing someone who has a mass lesion intracranially, because if you do, then you run the real risk of a herniation, a coning, and that patient could die. You could lose that patient. So how do you avoid that? Well, you think about what are the symptoms and signs that suggest raised intracranial pressure or a mass lesion. And again, they may be obvious, but the ones listed here I think are crucial. And if you've got a patient with seizures, if you've got a patient with papilledema, if you've got someone with a GCS less than 15, so by that I mean not just obtunded or comatose, but even with confusion, you don't want to be doing a lumbar puncture before some form of imaging, and you've got to consider it carefully and make sure that imaging is normal and it's safe to proceed. The other, I guess they're more obvious things to think about are if you've got a coagulopathy or if the patient is on anticoagulation. And the standard thing is like an INR of greater than 1.3. You wouldn't be doing an LP, and thrombocytopenia as well, you've got to bear in mind. And the last thing is if you have infection or a rash or something around the area where you're going to put the LP needle in, you don't want to be introducing infection into the CNS.
Very, very helpful guide there. In terms of analysis of CSF, that's a whole subject in itself. But I think the article has a really good guide on interpretation of results. And again, we could refer the watcher, the listener to that, I guess. Are there any other specific articles that you'd like to draw the reader's attention to?
Every single one is good. There is a whole article on autoimmune diseases, as I've already mentioned. I don't want to forget to mention two that I was particularly impressed by, and one is Professor Plant's article on visual disturbances in neurology, and that really goes through the anatomical and the clinical principles are needed to understand there and the different field defects, what they mean, very lucid indeed. And the other one is Robin Howard's article on coma and brainstem death. It's an area that people find difficult, obviously, to cope with such really lucid clinical, practical tips on how to examine and assess a patient with coma. So both of those recommended reading. That's
great. Thank you very much, Uma. It's been a real pleasure talking to you. So I think we have to close now. Thank you very much indeed for your time.
Likewise. Thank you very much, Albert. I enjoyed it.